Welcome to the EMS Handoff and a short outtake. We're going to talk a little bit about ABGs and how to make them easy when you look at them. We're going to turn it into child's play. And in order to do that, I'm going to share my screen so we can make sure that we can write on a couple of things and make sure that we are able to look at it. So we're going to make things real easy. All right, so interpretation of arterial blood gas is kind of a crucial skill that I want to make sure that we look at and we talk a little bit about, because whether you're an advanced EMT student, a paramedic student, a nurse, it's something that you kind of need to learn because it's going to help you understand stuff with different patients. So we're going to talk about what an arterial blood gas is, what the different components are. We're going to look at pH and partial pressures of carbon dioxide, partial pressures of oxygen. We're not going to dive too deep into how those are derived, but we're going to look at those. We'll talk about bicarbonate and some of the normal values in arterial blood gas and determine whether it's the pH is normal, acidosis, alkalosis, based on what our body likes to do. So the question is, what is an arterial blood gas? Well, an arterial blood gas is also known as an ABG. And an arterial blood gas is a laboratory test to monitor the patient's acid-base balance, and it's used to determine the extent of compensation by the buffer system. And there are three buffer systems. So the first one is our bicarbonate buffer system. So our bicarbonate buffer system works in our body to kind of buffer all the acids and everything else. Our second compensatory mechanism is the respiratory mechanism. And that's where we blow off the excess CO2, because the principal substance in our body that makes us acidotic is carbon dioxide. And then our last one is, of course, the renal system. And the renal system works to reabsorb sodium and get rid of excess hydrogen ions. So those are the three buffer systems. But the buffer system includes the measurements of the acidity, looking at the pH, the levels of oxygen, carbon dioxide in arterial blood. And unlike other blood samples obtained through a vein, a blood sample from an arterial blood gas is taken from an artery. So commonly the radial and the brachial artery, occasionally you will hear people talk about venous blood gases, also known as VBGs. But a lot of times they're going to talk about ABGs. We're starting to see more VBGs being drawn on patients, depending upon the setting that you're in. So what are the components of an arterial blood gas? So when we start looking at the components, there are 6 components that we're mainly going to look at. We're going to dive into a couple of these a little bit deeper, but the first one is the pH. So the pH is the concentration of hydrogen ions, and that kind of determines the acidity or the alkalinity of the body fluid. So a pH of 7.35 to 7.45 is what we consider normal. So that's the normal ABG level for pH. Anything less than 7.35 is acid. Anything greater than 7.45 is considered alkaline or alkalotic. So less than 7.35 acid, greater than 7.45 alkaline. So the next component that we're going to look at when we're talking about arterial blood gases is the partial pressure of carbon dioxide. So the partial pressure of carbon dioxide shows the adequacy of gas exchange. So what's moving in and out of the alveoli in the external environment. So we're talking about alveolar ventilation. And carbon dioxide can escape when there's damage in the alveoli. So any excess CO2 combines with water to form carbonic acid. So Basically, what happens with that is when you have water plus CO2, well, when you take those and you combine those together, now you've got 2 hydrogen, 1 carbon, 3 oxygen. So H2O plus CO2 equals carbonic acid. So those combine causing an acidotic state. So when we talk about that PaCO2, we're looking at the amount of carbon dioxide that's floating around the body, because CO2 is the principal acid substance that make in our body. So carbon dioxide cannot escape when there's damage in the alveoli. So that combines with water to form that carbonic acid that we were talking about, and that causes that acidotic state. So when there's hypoventilation in the alveolar level, for example, in COPD, the PaCO2 is elevated and respiratory acidosis results. So on the other hand, when there's alveolar hyperventilation, the PaCO2 is decreased, causing respiratory alkalosis. And for PaCO2, the normal range is 35 to 45 millimeters of mercury. Now, you'll notice for the ABG, and the partial pressure of what's dissolved in the bloodstream is closely related to that which we breathe out, because when we exhale, so that H2CO3 that we were talking about just a minute ago, that carbonic acid that flows around in the body, when it gets to the lungs, is acted upon by something called carbonic anhydrase. And that carbonic anhydrase then splits it up into water and CO2, which is what we exhale, which is why you blow on a cold window, and when you have that cold window, you'll see your breath fogging on that. The next component that we're going to talk about that you'll get with an ABG is the partial pressure of oxygen that's dissolved. So PaO2, or partial pressure of oxygen, indicates the amount of oxygen available to bind with a hemoglobin. So the pH plays a role in the combining power of oxygen with hemoglobin. And a low pH means that there's less oxygen in the hemoglobin. For PaO2, the normal range is 75 to 100 millimeters of mercury. Some textbooks may tell you 80 to 100, but some will tell you 75 to 100. For purposes of what we're going to talk about, we're going to say that the normal range is going to be 80 to 100 millimeters of mercury. Do not get this confused with pulse ox saturations. This is partial pressure that is dissolved in the bloodstream. You can certainly get above 100 millimeters of mercury with what's dissolved in the bloodstream with higher concentrations of oxygen, or you can get lower than that 80 based upon what's freely being given up. And the more acidotic a patient is, you will notice that partial pressure tends to drop because they're freely giving up oxygen from the hemoglobin. So the next thing that we'll talk just briefly about, we're not necessarily going to get from the ABG, but we'll get this from our patient assessment and the other tools that we have, is the SO2, okay, or the oxygen saturation. That's measured in percentage, and that's the amount of oxygen in the blood that we normally expect, okay? So an actual pulse ox is not measuring the oxygen, it's just measuring the saturation of the hemoglobin. It doesn't care what it's saturated with, but normally oxygen is what it's going to be saturated with. And it can be measured indirectly by calculating the PaO2 and the pH, but most of the time we're going to be able to get that from a pulse ox probe, okay? So oxygen saturation, the normal range that we want to look at is 94 to 100%. And once we reach that 100%, we don't know how much above that we're going, because it's only going to measure what's saturated on the hemoglobin. So we can actually get higher concentrations or higher partial pressures of oxygen into the bloodstream. But that's why we want to, post-arrest patients and other patients that we're monitoring, we want to keep it between 94 to 99%, because once we hit that magic number there, that 100%, we don't know how much more we're bombarding in the bloodstream. So we don't want to cause free radicals and apoptosis and other cellular damage by hyperoxygenation. Now, going back to some of the other stuff that we're going to get with an ABG, we're going to get the bicarbonate. Okay, we're going to get the bicarbonate. So HCO3, or the bicarbonate ion, is an alkaline substance that comprises over half of the total buffer base in the blood. So a deficit of bicarbonate and other bases indicates a metabolic acidosis. And alternatively, when there's an increase in bicarbonates, the metabolic alkalosis results. So HCO3 is what we're going to look at. So the normal value that we're going to look at with HCO3 is 22 to 26 milliequivalents per liter. Some people call it millimoles per liter, but it's milliequivalents per liter for what we're going to talk about, since that's what most medications and everything else are dosed in as milliequivalents. The next value, we're not going to dive deep into this, but something called the base excess, or BE. So base excess. So base excess, or base excess value, is routinely checked with the bicarbonate value. And a base excess of less than -2 is acidosis, and greater than +2 is alkalosis. So the base excess, the normal range is -2 to +2 millimoles per liter. So let's put all that together. So the normal values for an ABG. So what we got to do is we got to know what the normal values are. And those normal values are then going to tell us where we are, because we're going to have to take those normal value ranges and then plug them in to be able to figure out, is it acidosis? Is it alkalosis? Is it normal? Is it compensated, partially compensated, completely compensated? So to determine the acid-base imbalance, you've got to know and kind of memorize the values. It's not that difficult. So the normal range for an ABG is kind of used as a guide. And then the determination of the disorders is often based on the blood pH itself. So if the blood is basic, the HCO3 level is considered because the kidneys regulate the bicarbonate ion levels. And if the blood is acidic, the PaCO2, or the partial pressure of carbon dioxide, is assessed because the lungs regulate the majority of acid. The normal ABG values are pH is 7.35 to 7.45. And for PaCO2, the normal range is 35 to 45. And for PaO2, normal range is 80 to 100 millimeters of mercury. For HCO3, the normal range is 22 to 26 milliequivalents per liter. And there again, oxygen saturation normally is 94 to 100% if you want to complete that picture. And then the base excess is -2 to +2 millimoles. So now, in order to interpret arterial blood gas, we've got to, kind of look at it to detect whether it's respiratory acidosis or alkalosis, or is it metabolic acidosis or alkalosis, and especially during an acute illness, or when we're working with in a clinic or anything else. So to determine the type of arterial blood gas, the key components are checked. But we want to do this in kind of an easy and fun way. And to do that, we're going to use this fun little game that we all learned as a kid called Tic Tac Toe. So the goals of arterial blood gas analysis. So with given lab values, we need to determine if the interpretation is, acidosis or alkalosis, and kind of go from there. So in order to do that, I'm going to write down our goals of Abg analysis. So our goals of Abg analysis. So given the lab values, we got to determine if the interpretation is, first of all, is it acidosis or alkalosis. Very easy to determine. The second thing we got to do is the problem metabolic, or is it respiratory? And then the third thing that we got to look at, a little bit more complicated, are we dealing with something that is, acute? The body hasn't had time to do anything with it, so it is uncompensated, also known as acute. Is it partially compensated? Or has the body done its amazing thing and worked to pull that pH back to the normal range? Have we, exhaled excess CO2? Have we held on to the CO2? Have we made more bicarb? And now we are fully compensated. So which one is it? Well, we're going to use our wonderful little Tic Tac Toe method to be able to do this. So the purpose of this guide and what we're talking about here, we've got 3 goals that we've got to accomplish when interpreting this arterial blood gas. So based on the Abg values, determine if the values are acidosis or alkalosis. Then the second thing we're going to do is we're going to determine if it's metabolic or respiratory. Once we've done that, the last thing we're going to do is, is this an uncompensated, an acute thing that's happening right now? Is it partially compensated, or is it completely compensated? That pH is back in the normal range. So we need to keep these goals in mind as we'll talk about them as we're going through this. So the steps in Abg analysis using the Tic Tac Toe method, there are 8 simple steps for us to remember. And using those 3 goals, we'll break it down into 8 simple steps. So the first one we got to talk about and we got to look at is we got to know what the normal ranges are. So in order to interpret the ABGs, we're going to use that tic-tac-toe technique. We've got to know what our normal values are. So familiarizing yourself with the normal values, the 3 main things, the 3 main values that we want to look at are the pH, the PaCO2, and the HCO3. So the pH, normal range is 7.35 to 7.45. For PaCO2, normal range is 35 to 45 millimeters of mercury. And then for HCO3, the normal range is 22 to 26, and that's milliequivalents per liter. So that normal blood pH scale. So when we start talking about the normal blood pH scale, so right around normal is somewhere around 7.40. And that's kind of where our body likes to stay, somewhere in that range of 7.35 to 7.45. If we start going this way and dropping down, and we get down to below that 7.35, we know that that side is acidosis. If we end up going this way, then we're dealing with alkalosis. And once we get above that 7.45 range. So in between here, this is our normal range between here and here, with 7.40 being our midpoint. So once we get above 7.45, it's alkalosis. Once we get below 7.35, it is acidosis. Now, we're also going to look at a couple of other things here. We'll plug in our other two things that we're going to look at. So CO2 is the primary acid substance in the body. So if we get above 45, it is acid. If we get below 35, you'll notice that these two numbers are switched. And that's because if we get rid of the CO2, we become alkalitic. If we hold on to CO2, we become acidic. So you'll notice that these two numbers are switched, and that's on purpose when I wrote this down. And then for our HCO3, so this is our PaCO2. And then for our HCO3, the numbers are 22 to 26. Above 26 is alkalosis, below 22 is acidosis. So there again, the only one that is switched is that one right there. I want to make sure I point that out, because if I get a number that is above 45, like 50 over here, then we know that that is acidosis. If I get down below a number over here, let's say that that number is down to 30, then I know that I'm blowing off that CO2. I'm getting rid of that primary acid substance in the body. That makes me alkalosis. So thinking of that diagram we just drew and knowing what they are is kind of a recommended thing, or that way you can kind of remember it. And that PaCO2 is intentionally inverted or potentially switched or flipped for the purpose of the Tic Tac Toe method. So now here's the tough thing. In order to play that wonderful Tic Tac Toe, we got to make ourselves a nice, pretty Tic Tac Toe grid here. And so remember, the way that you win at Tic Tac Toe is 3 in a row. Well, we can't win this way. We can't win that way. We're not going to win this way. The only way that we're going to be able to win in Tic Tac Toe is 3 in a row going straight up and down. So with our Tic Tac Toe board, we'll set this up. So grab you a piece of paper. Let's write this down together. So Tic Tac Toe. So the first thing I want to do is I want to write acidosis on this side. We'll write alkalosis on this side. And then right here in the middle, nice and pretty, is all of our normal stuff. So once you've kind of memorized and think about the normal values and the diagram that I drew just a minute ago, create your blank tic-tac-toe board, label the top row as acidosis, normal, and alkalosis, and then based on the values, we're going to determine which column we're going to place the pH, the PaCO2, and the HCO3 in that grid. So we're going to determine if the pH is under normal, acidosis, or alkalosis. So that's kind of our third step. So the third step is to determine the acidity or the alkalinity of the blood with a given value of the pH. That's kind of our determining factor. And remember, back in step one, the normal pH range is from 7.35 to 7.45. So if the blood pH is between 7.35 to 7.39, the interpretation is normal but slightly acidosis. We'll place it in the normal column. If the blood pH is between 7.41 to 7.45, the interpretation is normal but slightly alkalotic. We're still going to place it in the normal column. So 7.35 to 7.45 all goes in the normal column. That's kind of important. Remember, we'll come back to it. So any pH that's below 7.35 is acidosis. It goes in the acidosis column. Any pH above 7.45 is alkalosis. And it's going to get placed in the alkalosis column. So kind of think about it this way. if my pH equals 7.35 to 7.39, okay, and I'm plugging it into my little Tic Tac Toe board, and I've got acidosis on this side, I've got alkalosis on this side, and I've got my nice normal in the middle, but my pH is 7.35 to 7.339, then I know that my pH is normal because it's in this range. So, but I could think of it being almost slightly, or is moving in the direction of acidosis. If my pH is between 7.41 to 7.45, then thinking about my Tic Tac Toe board, drawing the same thing here. Acidosis there. Alkalosis there. Normal there. But my pH is between 7.41 and 7.45, still in the normal range, but it is slightly moving in that direction. So with that 7.40 being my exact midpoint, I think about the other stuff. But remember, the normal pH, let me fix that, draw it in black. Normal pH should be between 7.35 to 7.45. All right. So once we would determine what the pH is under the acidosis or alkalosis, we'll kind of plot it on our Tic Tac Toe grid. And then we've got to determine if the PaCO2 is under normal acidosis or alkalosis. So what we will do for this, if the PaCO2 is above 45, we've got our Tic Tac Toe board built. So our pH is going to go in that first open one there. So we'll put acidosis here. We'll put alkalosis here. We'll put normal there. So if the pH is above 45, then what we're going to do is we're going to write down here, we're going to go PaCO2 because that is acidosis. If our PaCO2 is between 45 and 35, then we place it in the normal range. So if the PaCO2 is between 45 and 35, we draw out our Tic Tac Toe board. Then we put our PaCO2 here because it is in the normal range. If our PaCO2 is below 35, we draw out our Tic Tac Toe board. And if it's below 35, I know I'm blowing off that CO2. Then I take my PaCO2 and it goes in this range. And I know that it is alkalotic. So for this step, we need to interpret if the value of PaCO2 is within the normal range, acidic, basic, or alkalotic, and plot it in the grid under the appropriate column. Remember, the normal range for PaCO2 is from 35 to 45. If PaCO2 is below 35, place it under the alkalosis column. If the PaCO2 is above 45, place it under the acidosis column. And if PaCO2 is within its normal range, place it under the normal column. Now, we've got to determine if the HCO3, or our bicarb, is under normal acidosis or alkalosis. So what we're going to do for that is very similar to what we've already been doing. We're going to take the HCO3. If it is below 22, draw my Tic Tac Toe board. If it is below 22, that here, get it all drawn out. So if it is below 22, then I know that that is acidosis. And there we go. If HCO3 is between 22 to 26, that's our normal range. So I would take my HCO3, plug it right there. It's normal. If, for whatever reason, my HCO3 is above 26, then I know I'm making more bicarb for whatever reason. That's pulling my pH to the other side, making me alkalotic. Drawing my Tic Tac Toe board out here. So if it's above 26, then I know that we'll plug it right here on my grid, and that makes it alkalosis. So we interpret if the value of the HCO3 is within the normal range, acidic, or alkalotic, or the basic side, and plot it under the appropriate column of the tic-tac-toe grid. And remember, the normal range for HCO3 is from 22 to 26. So if the HCO3 is below 22, we're going to place it under the acidosis column. If HCO3 is above 26, we're going to place it under the alkalosis column. And if the HCO3 is written in its normal range, it goes under the normal. So now what we've got to do is we've got to solve all this for all the different goals and be able to look at everything. So now we're going to start solving for our goals and looking at the tic-tac-toe grid. We're going to determine what column the pH is placed, what column the PaCO2 is placed, what column the HCO3 is placed. So if the pH is placed under the acidosis column, it's acidosis. If the pH is placed under the alkalosis column, it's alkalosis. If the pH is under the normal column, then we kind of got to figure out which way it's leaning and interpret it accordingly. So then we're going to look at that. So then we're going to look at, is it metabolic or respiratory? So we're going to solve for the next piece of it. So as we do that, whatever column the pH is associated with and the corresponding PaCO2 or the HCO3 is going to tell us whether it's respiratory or metabolic. So if the pH is under the same column as the PaCO2, it's respiratory. If the pH is under the same column as the HCO3, it's metabolic. So it would look like this. So we'll say we've got a patient that's not breathing very well. They're hypoventilating for whatever reason. Maybe they got some broke ribs or something else. So that patient is probably going to be holding on to and retaining some CO2. At the same time, they're not going to feel well and everything else. So we get a pH, and we find that their pH is 7.32. So their pH is 7.32. We know that that is below the 7.35. So that pH, the 7.32, is acidosis. And we look at their partial pressure. Their partial pressure for CO2, wow, it's 54. Because it's higher than 45, we know that that is acidosis. And then we're going to look at their bicarb, and we see their bicarb is at 24. So it's here. So this is associated with the respiratory system. pH is under the acidosis. So this is respiratory acidosis. Okay, respiratory acidosis. And this is known as acute or uncompensated respiratory acidosis. Because that HCO3 has not moved anywhere. It's still under the normal column. So Tic Tac Toe, we got 3 in a row. That's associated with that PaCO2, which is respiratory. So we have respiratory acidosis. Simple enough. Let's look at it again. Let's talk about another one. So I've got my Tic Tac Toe board. I've got it all drawn out. I'm waiting on my ABGs to come back. I'm labeling everything. And I know we have this wonderful guy who has been eating Tums all night long. He's been having some GI problems over the last several months. And so he's been eating these Tums all night long, and we get his ABG back, and wow, his pH is 7.48. 7.48. Well, the normal range is 7.35 to 7.45. So 7.48 is alkalosis. So I put my pH there. And we see that, he looks like he's not taking a deep breath, but he's doing okay. And his PaCO2 is 35. But we get his bicarb, and his bicarb is 32. So now we have a patient this is associated with a metabolic component. The pH is under the alkalosis range. So now we have a metabolic alkalosis. Metabolic alkalosis, because this is associated with the metabolic portion. This is our respiratory portion, and he hasn't started compensating. He hasn't started holding on to that CO2 yet to bring that pH back this way. So this is uncompensated or acute metabolic acidosis. Alkalosis. So in order to see if there's any compensation, then what's going to happen is the factor that is not associated with the alkalosis or acidosis has got to pull in the other direction. So we'll talk about acute or uncompensated first. So uncompensated. So we're going to draw a tic-tac-toe board. We'll say that we've got a case that's out there, and we're just looking at what somebody drew. We're not worried about the exact numbers. We'll get back to the numbers in just a minute. But they've drawn this little tic-tac-toe board because they want to figure out what's going on. We'll take our last patient just to review that. This is uncompensated because this is uncompensated metabolic alkalosis. And that's because if this were trying to compensate, okay, if this were trying to compensate, it would pull that in that direction because the patient would start to retain some carbon dioxide to make them a little bit more acidic. And eventually what it's trying to do is it's trying to pull that pH back in that normal range. So let's, let me work to clean some of this up for a second here. We'll draw our lines back in. All right. So if this were partially compensated, this would want to move right over there. So what would happen is the patient would start retaining some carbon dioxide. And when they retain their carbon dioxide, let's say that number eventually goes up to 52. Well, that makes it acidotic. And now this is what we would call partially compensated. Because what it's doing is the other unassociated value has moved to the other side. When that unassociated value moves to the other side, what it's working to do is working to pull this pH back into that area. But it hasn't happened yet. If that pH does begin to come back down to the normal range, which is what we want it to do, and if that pH comes back to the normal range, we've got these two values on opposite sides here, but we've got a pH in the middle. We got to figure out what's causing the issue. Well, we know that this is fully compensated. Fully compensated. We'll talk about how to figure out which one it's closely associated with later, but this pH will recalculate and we'll look at a couple of things so we can look at what the actual underlying cause is when we get that. So if it's fully compensated, pH is normal. If it's partially compensated, all three values are abnormal. If it's uncompensated, if the PaCO2 or HCO3 is normal and the other is abnormal, then it's acute or uncompensated. So with that, let's actually plug into and do some problems. So we've got a patient that's got a pH. Grab your piece of paper, and I'm going to give you just enough time to do this before I start drawing it out. So the pH is 7.26. The PaCO2 is 32, and the HCO3 is 18. So remember your normal values, make your Tic Tac Toe grid, give you just a second to do that. I'm going to draw mine out while you're working to draw yours out. All right, and plug in your values. Plug them in, shouldn't take you long. So you got your grid. The pH of 7.26 is abnormal, and that pH of 7.26 is acidotic because it's less than 7.35. And the PaCO2 of 32 is abnormal. So which side does it go on? So we're going to place that, look at it. So that means they're blowing it off. They're getting rid of it. That goes on the alkalosis side. So that PaCO2 goes on the alkalosis side. And HCO3 of 18 is abnormal. We know that less than 22 is acidotic, so HCO3 goes here. Now, tic tac toe, we have 3 in a row. This value is associated with the metabolic piece, so that is metabolic acidosis. But all 3 values are abnormal. So this is metabolic acidosis. But we notice that that value there is way over here. It's going to want to pull that pH back. So because the pH is not back in the normal range, it's not fully compensated. So that means that this is partially compensated metabolic acidosis. Or you could say metabolic acidosis, partially compensated. All right, so let's do another one together. pH is 7.44. The PaCO2 is 30. And the HCO3, the bicarb level, is 21. So remember your normal values. Make your tic-tac-toe grid. And draw your stuff in. So the pH of 7.44 is, normal, but slightly leaning toward alkalosis. So we'll do that. We'll kind of recalculate it, and we're going to put an arrow pointing that way because we know where it's trying to go. And now the PaCO2 of 30 is abnormal. So we place the PaCO2 over here because it is less than 35. And the HCO3 of 21 is abnormal, and they've eaten up that bicarb, makes them acidic. So we place the HCO3 over here. So the pH of 7.44 is normal, okay, but leaning toward alkalosis. So I want to cheat, and I'm going to write pH over here. So cut pH 1, recalculate as pH alpha because it's leaning that way. Therefore, I still have tic-tac-toe 3 in a row. And because I got 3 in a row, this is associated with my respiratory. I have respiratory alkalosis. But the pH is in that normal range, okay? 2 values on either side are abnormal, but that pH is in that normal range. So this is what we would call, you guessed it, respiratory alkalosis with full compensation or fully compensated respiratory alkalosis. The only way to get something down is to continue doing it. So let's do another one together. pH is 7.1. PaCO2 is 40. And the HCO3 is 18. So draw your tic-tac-toe grid. All right, now you got your tic-tac-toe grid done. So 7.1 is less than 7.35. So that is acidosis. PaCO2 of 40 is normal. HCO3 is abnormal, so it makes it acid because it's less than that 22. So we place it over here. So this patient is in. This is associated with metabolic. Tic Tac Toe, 3 in a row. So metabolic acidosis. And we notice that this range hasn't gone anywhere. So this is metabolic acidosis with no compensation. So it's uncompensated or acute metabolic acidosis. So quick, down and dirty, that is all there is to the tic-tac-toe method. So the big thing to think about is acid-base balance and imbalances. So acid-base imbalances develop when a person's normal homeostatic mechanisms are dysfunctional, they're overwhelmed, and one type of acid and base imbalance is acidosis, where the blood is relatively just too acidic or a low pH, and the body produces two types of acid, therefore two types of acidosis, respiratory acidosis and metabolic acidosis. So two types of acidosis. One is respiratory. The other is metabolic. On the contrary, alkalosis is a condition where the blood is relatively too basic or too high a pH. There are two types of alkalosis. There are, you guessed it, respiratory and metabolic. So when acid-base imbalances occur, the body activates its compensatory mechanisms. So the body likes to maintain a nice homeostatic environment. So the body activates the compensatory mechanisms of the lungs and the kidneys to help normalize the blood pH. The kidneys compensate for the respiratory acid-base imbalance, while the respiratory system compensates for the metabolic acid-base imbalances. So does not correct the root cause of the problem, but it allows the system to restore some type of homeostasis until whatever's causing the illness or whatever's causing the problem to be fixed. So respiratory acidosis occurs when breathing is inadequate. So there's some type of issue with alveolar hypoventilation, and the lungs are unable to get rid of enough CO2, causing the PaCO2 or respiratory acid to build up. And the extra CO2 combines with water to form that carbonic acid. So we talked about that earlier. So that excess CO2 combines with that water to form that carbonic acid. And so that carbonic acid is a common occurrence in emphysema. So the kidneys activate its compensatory, albeit really, really slow, about 24 hours or more, by increasing the excretion of metabolic acids through urination, which increases the blood bicarbonate. So in emphysema, the kidneys kick in, they work to regulate. And since they're in that acidotic state, the body really, really likes the oxygen. So the other thing that happens with emphysema patients is a condition called polycythemia. So they have increased red number of blood cells. So because the kidneys are working, they secrete erythropoietin, and because they are very sensitive to hypoxia, they want more oxygen, so they secrete that. That gets circulated throughout the body, so the bones make more red blood cells, which they increase the amount of hemoglobin, and that's why we call them the pink puffers. Just a little side note. So types of respiratory acidosis, there are two forms of respiratory acidosis, acute and chronic. So with that, acute respiratory acidosis is a form of respiratory acidosis that occurs immediately. Left untreated, the symptoms get progressively worse. Chronic respiratory acidosis is a form of that develops through time. It doesn't cause symptoms to the body just adapts. So that's kind of the whole thing we're dealing with emphysema. So some of the risk factors, respiratory acidosis is typically caused by an underlying disease or some type of respiratory failure. So hyperventilation, so a decrease in ventilation increases the concentration of carbon dioxide in the blood and decreases the blood's pH. So brain trauma, coma, hypothyroidism, or myxedema. COPD, or chronic obstructive pulmonary disease, in chronic respiratory acidosis, the body tries to compensate by retaining more bicarbonate to overcome acidosis. And so respiratory conditions, the lungs are not able to eliminate enough of carbon dioxide. So excess carbon dioxide causes the pH of the blood and other body fluids to decrease, making them too acidic. So we would see that with the pneumothorax, pneumonia, status asthmaticus, those types of patients. And then drug intake. So overdose of an opiate or an opioid, such as morphine, tramadol, heroin, fentanyl, or some type of fentanyl analog, or even magnesium sulfate can cause respiratory acidosis. So some of the signs and symptoms of respiratory acidosis are, larger level of consciousness. Fix that. Altered LFC, confusion, disorientation, coma. So tremors are another sign. So those are some of the big things that you will see. And to manage that, the medical management of arterial, of respiratory acidosis, we see that. Sometimes, we may treat with medications, so some bronchodilator medicines and corticosteroids may be used to reverse some of the types of airway obstruction, weight loss in the morbidly obese patient, because, obesity causes hypoventilation syndrome. And so in some cases, we may have to provide mechanical ventilation through oxygen, supplements and other things. We may have to manage hyperkalemia through the use of various other things. And in the hospital or the ED, they may use K-exalate. So acidosis causes potassium. So every 0.01 drop in pH is a corollary increase in potassium that leaks from the cells. So acidosis causes potassium removed from cells to the extracellular fluid in exchange for the hydrogen ions, and alkalosis causes the reverse movement of potassium and hydrogen ions. So K-exalate increases the fecal potassium excretion through the binding of that potassium in the lumen of the GI tract, very rich area, and then your body gets rid of it. So provide IV fluids, electrolytes as needed. So respiratory alkalosis. So let's talk a little bit about that one. So that results from hyperventilation, since the lungs excrete too much carbonic acid, which increases pH. And respiratory alkalosis occurs quickly. The kidneys don't have time to compensate. And neurologic symptoms such as, confusion. So with respiratory alkalosis, we'll have, confusion, paresthesias, and cell membrane excitability can occur with that. So the blood pH, CSF, and ICF increases acutely. Some causes of hyperventilation include panic, hyperthermia, brainstem damage, central neurogenic hyperventilation, metabolic acidosis, DKA, pregnancy, because progesterone levels are increased during pregnancy, and progesterone causes stimulation of the respiratory center, which can lead to respiratory alkalosis. Plus, the fetus likes a nice, warm, alkalotic environment to grow in. So salicylate toxicity causes respiratory alkalosis as well. So hyperventilation is a sign that respiratory alkalosis is most likely to occur higher carbon dioxide levels in the blood also have a number of physiological effects. So the patient may be, have numbness, tingling, palpitations, even muscle tetany or some type of seizure, convulsions. And in order to manage that, one of the things we got to do is coach the patient to slow their breathing down. Sometimes it's going to be difficult, and eventually we'll correct some on its own. Sometimes with medications, relaxation techniques. So those are a little bit difficult. So let's talk a little bit about metabolic acidosis. So that occurs when there's a decrease in the bicarbonates and a buildup of lactic acid. So that happens in diarrhea, ketoacidosis, ketosis, and kidney disorders. Some of the risk factors, of course, are DKA, especially with type 1 diabetics, chronic renal failure, chronic hypoxia, obesity, diarrhea, dehydration, aspirin toxicity, methanol poisoning. So those are just some of the things to think about. Some of the signs and symptoms you might see with that might be an altered LOC, confusion, disorientation, a lot of the other same common things, but add jaundice to that one. In order to manage that, it really depends on what's going on. And that's kind of where we start looking at base excess and ion gaps, which you'll hear a lot about from Christopher from future episodes and stuff like that. So Tyler Christofouli does an excellent job with talking about metabolic acidosis and ion gaps. So, and how to treat those underlying things. So with metabolic alkalosis, that can happen from, risk factors for that could be vomiting, sodium bicarb overdose, too many Tums, hypokalemia, nasogastric suctioning, and some of the signs and symptoms, numbness, vomiting, diarrhea. So lots of things that we can do with those. So let's do another quick interpretation, just one or two, and we'll do those quickly to see kind of how you feel with that. All right, so the first one. We've got a gentleman who's a 54-year-old widower with a history of chronic obstructive pulmonary disease, and he was taken to the emergency department with an increase in shortness of breath, pyrexia, productive cough with some yellow-green sputum, and difficulty communicating because of his inability to complete a sentence. One of his sons said he's been unwell for 3 days, and upon exam, he's got some crackles, some wheezes in the lower lobes. He's tachycardic, bounding pulse measurement of his ABG. He's got a pH of 7.3. He's got a PaCO2 of 68 and an HCO3 of 28. And his PaO2 is 60. So draw your little Tic Tac Toe board here. So that pH is 7.3, that is acid. That PaCO2, he's retaining a lot of that. So above 45 makes that acid, so that's PaCO2. And that HCO3 is 28, so it's above 26. So the HCO3 goes over here. This is not a value we're using, but something important to think about. So we know that this is associated with respiratory, so we have respiratory acidosis. And with that, we know that it's partial compensation. So it's respiratory acidosis with partial compensation. One of the other things I will point out is this PaCO2 of 60, because he's acidotic, he's freely giving up those oxygen molecules to the acidic cells. So he's in respiratory acidosis with partial compensation. All right, one more, because this guy's really, really sick. So this is a pediatric patient who kind of rushed to the hospital due to vomiting, decreased level of consciousness. The patient displays slow, deep, Kussmaul breathing. You know where we're headed. He's lethargic. He's irritable in response to stimulation. He's dehydrated. Eyes are sunk. Mucous membranes are dry. Has a 2 week of polydipsia, polyuria, polyphagia, weight loss. So his ABG shows a pH of 7.0, a PA CO2 of 90. Sorry about that correction. That's PaO2 of 90 millimeters of mercury, a PaCO2 of 23, and an HCO3 of 12. All right. Some other things we'll come back to later. His sodium is 126, potassium of 5, chloride's 95. We may come back to that one after Tyler Christofoli talks to us a little bit about metabolic acidosis and ion gaps. So here we have acid. Here we have normal. Here we have alkalosis. So at pH is 7.0, that pH is acid, definitely acid. The PaO2, I'm not worried about that right now, so let's circle that just to keep it on the side. PaCO2 of 23, so that tells me that he's blowing it off. That's alkalosis because those numbers are switched. HCO3 of 12. This is associated with metabolic, so this is metabolic acidosis. That's on the opposite side, so this is metabolic acidosis with partial compensation. So metabolic acidosis with partial compensation. All right. So that kind of wraps us up a little bit about how to use the Tic Tac Toe method, and some quick and easy ways that we can do things to understand ABGs using the Tic Tac Toe method. So this is my handoff of information to you using the Tic Tac Toe method. And I certainly hope that you got a little something out of this. Make sure that you check out the EMS Handoff with Tyler Christofoli and Metabolic Acidosis with anion gaps. And after that, we're going to try to come back with another outtake for the EMS Handoff. Never underestimate your value of your handoff.